Thank you very much. I know we're running late, but it's my obligation to formally express my gratitude to the Society for this privilege of being invited back to Rio. President Carlos Virginie, I thank you, the Secretariat, Sergio, and Julio, tremendous organization. I thank my good friend Arno von Riestau, the Scientific Director, for considering me for presenting at this work, and obviously my very good friend José Luis. I'm very pleased to see and meet some very new friends as well. I have to come back to Rio every so often because otherwise my life will not be happy. It's a happy place in Rio, so it's good for me to come back. Anyway, you may start my time now. So here's the question. We started yesterday when we talked about the diabetic foot. And yesterday I mentioned that there were three priorities, including tibial revascularization as an angioplasty first approach. I talked yesterday in particular about limb salvage and preservation of foot function through a local foot surgery. Today, I want to talk about the third option, which is this whole concept of angiosomes. And is it possible or is it necessary to tailor our approach to revascularizing the foot? Is it time for vascular surgeons to think differently about the foot, not just about perfusing a tibial vessel, but concentrating on where perfusion needs to be? So this here has been the adage that I was taught many, many years ago. You must establish inline flow to the foot. And in fact, when you look at task 2, they say that the recommendation here is you must do the least diseased distal artery regardless of localization to perfuse this foot. But we know that there are many studies that despite excellent results and long-term patency rates, there still is clinical failure. The foot is not salvaged. Up to 10% of these well-revascularized legs still require an amputation. So we haven't done this. And this is where the angiosome concept comes into play. I think this is now a familiar concept, but it basically deals with the source artery and the fact that it supplies not just the muscle, but the subcutaneous tissue and skin, which is where the ulceration occurs. Now, there are many foot angiosomes. There are about 6 foot angiosomes, so this is also known to this group. But I also comment that it's constant in 95% of patients, but the boundaries can be variable. And I think this is something I will emphasize. We know the dorsalis pedis artery angiosome, and even though this is most frequently revascularized, if you have an ulcer in the metatarsal head, in the plantar surface, perhaps you don't reach as efficiently through this dorsalis pedis. The posterior tibial angiosome is, I think, very important, not just for the calcaneus, but also for the branches, which supply both the lateral and medial plantar aspect of the foot, but in addition is partially responsible for the calcaneus. There was a question yesterday, what do we do with these calcaneal ulcers? And obviously, being able to perfuse these directly is quite important. The posterior tibial angiosome, in my mind, is very important, and trying to establish flow to these regions, especially to these specific branches, may be something to consider. The perineal artery is also important. It's the vascular surgeon's friend, because it, sometimes is the only remaining outflow vessel. But really, it's confined, if you will, to the calcaneus. In that region. One concept that surgeons know quite well is collaterals, and we have to know the concept that these foot angiosomes are interlinked with all these choke vessels. So for instance, this study here with my good friend Chris Attinger, a cadaver study, show that you can have the angiosome of the heel can be supplied by 2 arteries. So the perineal is okay, as well as the posterior tibial can supply it. And you can see that they have a rich network between here. So now, knowing the angiosomes of the foot, is this now represent an opportunity for us as surgeons and as interventionalists to match the treatment to the clinical syndrome? Why not achieve the best possible perfusion to the tissue that's in need of revascularization? So is there any evidence for this? I recently, and it's going to be published soon, we did a systematic review of the literature with regards to this. And you can't read all of this, but looked at how they revascularize, the severity of the lesions, the feeding arteries, direct revascularization versus indirect revascularization, technical success rate, and so forth. We looked at limb salvage rate, wound healing rate, time to healing, amputation-free survival, and so forth. And the publications, you see, are starting to increase. There are about 11 publications that truly have some kind of series related to this question. But there are some very interesting facts that you'll start to see when you look at these individual series. So here is an old one from 2009, which shows and compares direct revascularization versus indirect revascularization. And I point out to you, for instance, here when you look at complete healing in red, with direct revascularization, it's 91% in this series, and 9% failed to heal. Indirect revascularization, 38% healed, 62% did not heal. The point here, though, is that when you do direct revascularization, why is it not 100%? Right? Despite the fact that you directly revascularize the angiosome, you will have some failures. In addition, when you look at indirect revascularization, right, 38% of the wounds still heal, not zero. So I think when you start to look at these studies, you now start to get some insight into perhaps the importance of these topics. Lida in Journal of Vascular Surgery showed direct versus indirect for isolated baloney. You have some Alexandrescu shows the importance of the different angiosomes trying to make this. But all of these studies are not prospective. And I'll go through some of the limitations that are associated with this. You see all of these that are here. So the question here is angiosome-supported revascularization evidence-based. I believe that all of these studies that we reviewed, they're all preliminary and they're retrospective. Right? In addition, there's problems in the selection. The patients are heterogeneous, different kinds of comorbidities, different types of chronic limb ischemia, different pathologies, types of ulcers, clinical endpoints, follow-up, all different in all of these studies. Here was a study done in Japan by my former postdoc, Azuma, in Asahikawa, and he presented this at the European Society for Vascular Surgery. And he showed, for instance, that if you look at the data by itself, and this is his own data, end-stage renal disease or without it, he shows here that with end-stage renal disease patients, if you have renal disease, it seems that angiosome-directed revascularization was superior to indirect revascularization. However, the point that's made is if you do a careful analysis through propensity score matching, there's no difference. Right? So again, when you look at all of the data that's now being presented here, right, it's not clear. We don't know enough about the role of arterial collaterals, and we cannot quantify precisely how to quantify before and after limb revascularization that is here. And so sometimes the most convenient and the most suitable angiosome, right, is not necessarily the simplest one to revascularize. When you look at this, it's blocked, it's a stenosis, you have to do all of this, and then you have an easy way out with an easier target. So again, it's not easy to do this. There's some caveats. We know that the more proximal and unspecific the revascularization, the greater the dependency on the remnant collateral reserve. Patients with diabetes have less foot collateral reserve or so-called choke vessels. You do so many angiograms here or look at this. We know that having an intact pedal arch, which is a major collateral pathway between angiosomes, is rare in diabetics. And some have calculated that it's probably only present in as low as 10% of patients with diabetes. So you lack this intact pedal arch, which is the gateway to supply and cross different angiosomes. Sepsis, when you have a patient with a septic foot, right, that comes into the emergency room, you may have thrombosis actually of some small collaterals. So even though angiographically there should be some collateralizations, the presence of sepsis in that diabetic foot will actually cause some inflammation and impede that. So again, when you look at pedal flow in the diabetic with chronic limb ischemia, you see so many different patterns, and you don't necessarily see an intact arch in many of the cases. And in the presence of infection, you actually get compartmentalized flow in the foot, which prevents adequate angiosomal perfusion. We know that angiosomes are less important in patients who don't have diabetes. Patients who have rest pain and no tissue loss, the angiosome is probably not so important. Lesions above the ankle, probably not important to angiosome concept. If you have a superficial ulcer, less than 10 millimeters in diameter, if you have a toe pressure that's even adequate, you're okay. And if your pedal arch is intact, angiosome concept probably is not as important. We know that the angiosomes are variable. So when you look here, for instance, this here shows the angiosome here for the posterior tib in the medial, but you can see here for this patient, the angiosome pattern is different, right? So there's some variability in the pictures of these angiosomes that may not quite be interesting. There are differences in collateralizations in choke vessels. These choke vessels respond to aging as one gets older, the pathology that generates it, whether you have diabetes or end-stage renal disease, and the localization of each angiosome, right? You have a large collateral network depending on where the wound is located. The question here is, if you have a boundary angiosome, when do you revascularize it, and do you need to match the angiosome revascularization to tissue perfusion? The key here is we don't have any way of assessing perfusion to these things. There are a number of techniques that are around, and I think this is the future for looking at perfusion to this fit. We've been playing around with hyperspectral imaging as a way to try to detect areas of perfusion that are localized to the ulceration. Jason Chin is my resident now, and we are conducting these studies to look at this. And fluorescent angiography using indocyanine green is now gaining this rapid application to be able now to try to match the intensity of perfusion and trying to identify whether or not the particular angiosome is being perfused specific to the wound. So in conclusion, I think angiosomes help explain some of the variability of results of revascularization for chronic limb ischemia. I think it's an opportunity for target therapy. It may help determine the best strategy in some subgroups of patients. Healing is more likely after direct revascularization of the correct angiosome, but I don't think it's correct to deny a patient an indirect revascularization. There are many wounds that are healed, and there's variability of angiosomes and their choke vessels. So I conclude that with bypasses, you get higher local pressure and physiologic pulsar flow. Endo gives us the advantage of opening 2 or several tibial and foot arteries simultaneously. I think these have to be complementary, and I think this is why the vascular surgeon, as the interventionalist, is poised to be the leader here. We can do both open and closed intervention to try to heal this. And lastly, we need to be able to assess perfusion to be able to assess our therapy. Thank you very much.
Dr. Bauer, antes dos comentários do Dr. Luiz Carlos, a gente vai prestar homenagem ao Dr. Bauer Sumpio, convidamos o doutor, nosso presidente, Dr. Carlos Virgini, para entregar uma placa em agradecimento à sua participação. Vai lá. Cadê o Dr. Bauer? E lembrar que o senhor certamente é convidado para outros eventos. Então, Dr. Bauer. Eu aproveito para convidar também, vamos fazer a sessão homenagem, vamos convidar o Dr. Darren Schneider, o Dr. Júlio Peclá, nosso diretor de publicação, vai fazer entregar a placa para ele também. Dr. Darren. Vamos prestar outra homenagem também a outra convidada nossa nesse evento, a doutora Jade Iramoto. Eu convidaria o nosso presidente da nossa mesa, doutor Antônio Vieira de Mello, para fazer a entrega dessa placa. Yeah. E, para terminar, eu convidaria o nosso diretor científico, Dr. Arno von Richthof, para fazer a entrega de uma placa a um dos nossos conferencistas, Dr. Christian Bianchi. Para a gente não perder tempo, lembro que no final, por decisão presidencial, vai ser feita uma foto conjunta com todo mundo com as suas placas. Para a gente ganhar tempo, vamos avançar então. Vou passar a palavra ao Dr. Júlio Peclá para conduzir os debates.
Gostaria de pedir ao Dr. Luiz Carlos que fizesse os comentários sobre a palestra do Dr. Bauer, por favor.
Dr. Bauer, parabéns pela apresentação, um excelente padrão. Durante muito tempo a gente acreditou que talvez a revascularização distal, que era feita brilhantemente por vários colegas, um deles aqui ao nosso lado, o Dr. Antônio Vieira, a gente achou que talvez a angioplastia distal, infrapatelar, fosse a última ou a mais difícil de de vir a substituir as cirurgias. E durante muito tempo também a gente acreditou muito nas colaterais. A gente colocava todas as nossas esperanças na colateral, porque a gente escolhia um vaso, é o que tinha, e a gente operava esse vaso e acreditava-se que os resultados eram muito bons. No seu trabalho, o senhor desmente um pouco isso. E hoje, a primeira opção para angioplastia, para o procedimento intravascular infrapatelar, é a angioplastia, e além do mais, ela mostra para a gente que, além de tudo, ela ainda pode ser mais objetiva, ela pode revascularizar áreas específicas para regiões que especificamente precisam de um aumento da perfusão. Na verdade, isso só vem a complementar que a angioplastia infrapatelar ela é a melhor opção hoje. E existe algum caso em que o senhor faria a ponte ainda, em alguma situação, ou angioplastia, você tenta de qualquer forma, mesmo que tenha um vaso no dorso do pé que você não consiga reabrir?
I'm sorry, what was
acho que é a última pergunta só. Em alguma situação em que o senhor tem uma artéria no dorso do pé e que o senhor não consiga reabri-la, a opção cirúrgica, com certeza, ainda é essa. Ou o senhor tenta por baixo e normalmente não usa a revascularização.
Thank you. I tried to make the point that having an idea, the concept of angiosomes, is very attractive because for surgeons it seems black and white. You look at the zone and you revascularize it and everything will be well. If it's not in the zone, the traffic won't go there, and so it should fail. But I think the lessons that I tried to discuss in my talk was that it's still not clear. We do not have a good way of assessing perfusion to a particular angiosome. We only have information from a radiological point of view. We see a picture, but we don't actually assess perfusion, which is necessary for wound healing in that particular area. We also don't know what is the threshold for adequate blood flow. How many mLs per minute per gram of tissue do we need to heal a wound? And is that what we are supplying? We generally provide much more than that, but the question here is if we are just at that threshold, the wound should still heal. So I think angiosome concept has been very popular. It's very hip. Everybody likes to talk about the angiosome concept, but I'm not sure that that's the final word yet.
Muito obrigado, Dr. Bauer. Vamos convidar o nosso próximo conferencista, o Dr. Darren Schneider, para falar sobre acesso podálico retrógrado.